So next we have Professor Major General J.K. Parihar sir. He'll be speaking on comparison of functional outcomes between FLACS and MICS in post-radial keratotomy cataract.
Thank you, ma'am. Uh, Post-radial keratotomy eyes poses a big challenge. One is with the calculation of IOL power, and second is the intraoperative dehiscence and unstable anterior chamber. With this aim, we have analyzed the pattern and compared the functional outcome between FLACS and conventional phaco in post-RK cases. We have retrospectively studied 70 eyes, of which 38 eyes had undergone FLACS with toric IOL. Amongst the 70 eyes, RK cuts were as follows. Maximum 34 eyes had 12 cuts, and 22 eyes having 16, and remaining 14 eyes had 8 cuts. Preoperative astigmatism was ranged from plus minus 2 diopter to 5.5 diopter in both the groups. A moderate nuclear grading in all cases except one case of hypermature cataract, and our follow-up period was ranged from 6 months to 2 years. The statistical analysis was carried out on SPSS software by a qualified statistician. For statistical significance, p-value of less than 0.05 was considered statistically significant. IOL power calculation was done on all cases on IOL master. Initially, when 700 was not available, it was on 500. A combination of SRKT and Hoffer Q was used in 15 eyes, and subsequently the remaining 55 eyes, we had gone with the Barrett's true case based toric calculators. All cases had undergone hydrophobic single piece toric IOL. The standard phaco-dynamics were used for the MICS cases. Direct paracentral chop with the help of a 15-degree straight tip was carried out. For the FLACS, there was a titration of the energies for the different steps, and higher settings were taken for the corneal incisions, 2.8 into 1.4 millimeter, side port 1.2 into 1.3 millimeter, and especially in the anterior capsulotomy, after initial 2 cases, we had to raise the power substantially to avoid the tax, etc. The lens fragmentation and softening was carried out. Here again, the safety margin for the posterior capsule was raised to the 750 micron as compared to the conventional settings of the 500 microns. These are the FLACS machines showing the different, these are the surgical steps. Here you can see this case is a high myope who had undergone RK 30 years ago, and now she has come with such a high hyperopic changes, 34 diopter into 4.5 diopter of the cylinder. When we compare the complications between MICS and FLACS, the wound adhesions was the most common problem in both the groups with higher incidence, and most of these cases were of the 12 and 16 cuts. Incomplete rhexis in the 2 cases of FLACS were the initial cases, and later on with this experience we have raised the energy settings, and hence we got the better outcome. We compare the residual cylinders in the both right and respective in MICS and FLACS cases. There was a substantial decrease from the pre-operative cylinder in the cases of the FLACS, and again this is showing the same findings. When we compare the residual sphere between SRKT and Barrett formula, the Barrett formula has definite superiority and edge over the SRKT in the post-RK cases. Rotational stability by logically was found much superior in cases of FLACS because a well tensile strength and the uniform well guided rhexis given a better position of the lens. When we compare these challenges, we have found that rhexis was the major issue along with the changes in this opening in the incisions, and TrueNet formula has provided better predictability to presume the IL power. Here the FLACS linked AIOCT lead to the precision in fashioning the incision, rhexis and nucleotomy. Thereby there was a least surgical manipulation over the incisions, and rotating the nucleus, less energy was used. So overall in a compromised corneal, and we have got the better outcome in the FLACS cases with the less endothelial cell loss. In our view, the invention of newer formulas for calculating IOL power, higher and phacoemulsification machines availability, and the FLACS have revolutionized the precision and outcome of cataract surgery in post-radial keratotomy cases. Thank you very much.